Good afternoon, everybody. Good afternoon, participants online. Welcome to this month's eco session. We're here at the SEED Global Health Offices. And as usual, where we have our eco sessions from, this is in collaboration with the Ministry of Health. Participants online, welcome to this phase of the eco sessions. This eco session is going to be a very interesting one. It's going to be different. And the theme for this eco session is based on the deteriorating patient. For those of you who have been attending previous eco sessions, we've had a lot of teachings on the deteriorating patient, but this session is going to be focused on pre-hospital care. Pre-hospital care is the care given to a critically ill patient outside the hospital. And this time we're focusing on ambulance transfer. So we have a patient who is an emergent patient who is en route for specialized care within an ambulance. So my pre-hospital brothers and sisters, this is your time to shine. We're going to focus on you for this eco session. And with me, I have a team of specialists, a team of experts, both pre-hospital experts, but also experts that are involved in the field of emergency medicine. And I'm going to introduce them one by one. I will start off with the pre-hospital team. We have Joseph Senkumba here. Joseph, please introduce yourself.
I am Joseph Senkumba from the Association of Ambulance Professionals and EMT by training. Thank you.
Thank you, Joseph. I have Andrew with me.
Hello, everyone. I'm called Andrew. I'm EMT and I work for the Ministry of Health and Guru and Dispatch Center. Thank you.
Okay. I'm now going to introduce the other team of experts. I have Dr. Simon.
Hello, everyone. My name is Dr. Simon Dumsime. I'll be the medical officer working in Masaka.
Yes, we're going to do a lot of role playing here. We're going to do a simulation. So for those of you who are not sure what a simulation is, it's more of an acting. It's more of trying to create a real life scenario. But the beauty about simulation is that the patient is not real, but it's a teaching experience and it allows us to make mistakes. So the next doctor is Dr. Rebecca.
Good afternoon, everyone. My name is Rebecca Asimir. I'm a second year emergency medicine officer at Deteriorating University.
We have Dr. Rachel.
Hi everyone, my name is Rachel Kagala. I'm a third year emergency resident from Makere, also working as a coordinator for Deteriorating.
Okay, we have Dr. Anne Kaguna online. Anna, if you're online, please unmute and introduce yourself.
Hi everyone, this is Dr. Anne Kaguna, emergency physician. Thank you, glad to be here.
Okay, I have not introduced myself. My name is Doreen Okong Alalate. I'm an emergency physician and I'm a SEED educator at Makere University. So I'm going to be your moderator for this session. That means I'm going to run the scenario. I'm also going to lead the case discussion and debrief at the end of this scenario. So our scenarios is starting from Masaka Regional Referral Hospital. We want to simulate to you what would happen in real life. At Mulago National Hospital, we receive referrals, being it's a specialized hospital, and we receive referrals from different regional referral hospitals. And Masaka is one of the hospitals where we receive patients. So this case is based on a trauma patient that arrives at Masaka Regional Referral Hospital, is stabilized, and the decision is made to refer the patient to Mulago Specialized Hospital for further care. We are going to start off this eco session with a simulation of how a patient is stabilized at Masaka Hospital. And the simulation is going to be run with Dr. Simon, who will be the medical officer, Dr. Rebecca, who will be the nurse at Masaka Regional Referral Hospital. So Simon and Rebecca.
Thank you. Thank you, Dr. Doreen. Emma, would you kindly go to join us?
All right, team, are you ready?
Yes, we are.
Okay, so Simon, please assign the roles to your team.
Hello, Tim. Good morning. Today is our shift today. We are preparing to receive patients. Can we give the roles that we are all comfortable with? Rebecca, are you comfortable with?
Comfortable with circulation and
All right, good. And then Emma, are you comfortable with?
I'm comfortable with text organization in this form.
Okay, very good. All right. So we will prepare our equipment. We'll also prepare our personal protective equipment. And if the patient comes in, if it's trauma, Emma, you will be in charge of the head stabilization, manual inline stabilization, and then Rebecca, you work with me as we assess and intervene for the patient. Is that okay?
Yeah.
All right.
Are we ready, team?
Yes, we are.
All right, Simon, you are the doctor in the emergency department on shift. You have been called to assess John Mukasa. John Mukasa is a border rider. He's just had a road traffic accident along Basaka Highway, and you have been called to assess this patient. So please repeat the scenario back to me.
All right, so there's a border rider, 30-year-old male, was involved in an accident. Is going to be brought in by the family or police?
He has been brought in by police.
By police, right? And we're preparing to respond. So we're anticipating trauma. So in line with our preparation, so team, if we are ready, let's have our personal protective equipment, and when they let us know, we will proceed to respond.
So you're putting on your PPE right now.
Okay, so we speak sometimes. Okay.
Okay, so the scene is safe for you to approach.
Okay, so it's on. We have our aprons on, our face shields, our gumboots, and all the necessary equipment. The scene is safe for us to approach.
Yes, scene is safe for you to approach.
Okay, so as we approach, because the patient is trauma, Emma, would you start by stabilizing?
Oh, my leg, my leg. Patient is complaining of pain in the leg. My leg, my leg.
Hello, Mukasa, how are you?
My leg, doctor, my leg, my
Mukasa,
leg.
so my name is Dr. Simon. I'm here to help you. So based on how the patient is talking, he seems a little bit confused, but the airway seems patent. Emma, do you see anything in the mouth?
There are no secretions, the airway is clear.
Okay, so the airway is clear for us. So continue stabilizing continuing manual inline stabilization. Because of the mechanism of injury, we suspect there might be cervical spine involvement. Rebecca, could you work with Emma to at least put a cervical collar?
so we are going to put a cervical collar into our patient to stabilize their spine. So first we are going to measure from the angle of the chin, the junction of the sternocleidomastoid muscle. So that is about 3 centimeters, 3 finger breadths, rather. So I will come to my C collar and I will measure. Okay. Okay. So I'll come and place. Okay, are you stabilizing it? Slowly slide it under the neck. And fully attach my C collar, making sure that the midline is quite visible, the trachea is quite visible to the eye.
Okay, well done, Rebecca. Well done, Emma, as well. Emma, continue stabilizing, doing manual inline stabilization. Thank you, good job. So in the meantime, we're going to assess our breathing. Could you please touch the monitors for SpO2? I will start with the look, listen, and feel method. Expose the chest.
So when you expose the chest, the patient's respiratory rate is at 25 breaths per
So
minute.
we have a high respiratory rate of 25. Do I see any accessory muscle use?
Yes, you're using abdominal muscles for breathing.
Okay, am I seeing any obvious penetrating injuries to
There are
the torso?
no penetrating injuries, no lacerations, no bruises,
All right,
chest deformity.
no chest deformities. Okay, so palpating, how is the chest expansion?
Bilateral chest expansion.
Okay, any tenderness? Are there any broken ribs? Any subcutaneous emphysema?
No subcutaneous emphysema, no tenderness, no crepitus.
Okay, good. And how is our trachea?
The trachea is midline.
Trachea is midline. Okay, I'm going to auscultate to listen.
You have normal breath sounds, 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 normal breath sounds.
Are there any added sounds that I had?
No added sounds and there's equal air entry.
So because there are no added sounds and there were normal breath sounds, I will not percuss. But based on our breathing assessment, we have an elevated respiratory rate of 25. We have, how is oxygen saturation? Oxygen saturation is about 89, which is reduced. And then we also have signs of respiratory distress, use of accessory muscles. So for now, Rebecca, could you start by putting oxygen, give 10 liters with a non-rebreather mask, we'll titrate as needed later on. Is that okay?
Yes.
Let me know once you're done doing that.
So once you attach oxygen, the oxygen saturations go up.
Okay, well
They
done,
go up to
Rebecca.
about 94.
Okay, so we're done with our breathing. We're going to move on to our circulation. All right, and I'm going to start doing checking for signs of shock. How are the extremities? What's the temperature?
Extremities are warm,
Okay, are they clammy?
not clammy.
Not clammy. How is the capillary fill?
Capillary fill is less than 3 seconds.
Okay, so that's normal. The extremities are warm, that's also normal. How is the pulse rate? Based on
Pulse
the
rate
monitor?
is regular, normal volume.
Normal volume.
On the monitor, as you can see, his pulse is about 130.
130. Okay, so we have an elevated pulse, but the pulse volume seems normal. Rebecca, could you please attach the blood pressure monitor? Okay.
Blood pressure has been attached.
Press NIBP.
Okay, I can help you press. Okay, great. So the blood pressure is measuring. In the meantime, I'm going to check for any distended neck veins.
Not distended neck vein.
No distended neck veins. Yes. Yes. How is the heart?
Normal heart sound.
Normal heart
There are
sound.
no mammals.
Then there are no mammals. Okay. And is there any obvious bruising?
There is no bruising to the chest cavity.
And then
There's
the
no
pelvis.
no external bleeding. The pelvis is stable.
Okay, very good. So Tim,
The BP is on the machine.
so the BP is on the machine. Our BP on the machine says that it's 130 over 100. Based on our blood pressure, 130 over 100, that's okay and expected. For now, moving on, based on our assessment, our C, there are no signs of shock. The most significant finding is 130 over 100 with an elevated rate. We're only going to give some maintenance fluid of 500 mils, right? But could you please put a line, take off blood samples for blood grouping and cross-matching, CBC, and also because our pulse rate is high, could you please also start pain medication? I would recommend IV paracetamol to help at least in this moment. So you do those and let me know once you're done.
All right, thank you.
Okay. Okay, so you remember IV paracetamol for the pain.
Yes.
You're taking off blood for blood
Taking off
grouping,
blood for
cross-matching.
cross-match.
and then CBC as well,
Yes.
and any other tests that we might need later on. And then putting 500 mils of normal saline, running as maintenance as we keep on reassessing and see if there are any signs of shock. Is that okay?
Yes.
Okay, so moving on, once we're done, moving on, I'm going to assess our disability. Okay, I'll start by assessing the level of consciousness. Is Mukasa looking at me?
No, he's not looking. He's not opening the eyes
He's
continuously.
not opening the eyes continuously. Okay, Mukasa, does he hear when I call him? Does he open the eyes?
The eyes to voice.
Okay, how about when I put pain? Does he open eyes?
Opens the eyes to pain.
Alright, so Tim, our eye opening is on 2, right?
Yes.
Okay, so moving on to the bubble. Mukasa, can you talk to me?
He's very confused. He thinks he's.
Where are you, sir?
I'm in the market. Are you my mother? He's very confused.
So based on our verbal response, this is not normal talk. This is definitely confused. We'll score that with 4. So far we have 6, right? Mukasa, can you squeeze my hand?
He squeezes your hand very slightly.
Very slightly. So he is able to obey commands. Based on our motor response, that would be a 6. So in total, we have 12 out of 15. Obviously, that diagonizes a moderate traumatic brain injury. So based on our blood pressure as well, could you please start monitor and let me know because we suspect there might be, we don't want to get any signs of increased intracranial pressure. In the meantime, I'll proceed with our disability assessment. Okay,
Has been connected.
very good. Could you also take off blood for blood glucose testing? In the meantime, I have a pen torch, so I'm going to assess the pupils.
The
Okay.
pupils are equal and reactive to light.
Okay, so
They're
they're
about 3 millimeters.
okay, so pupils are equal and reactive to light. Obviously, we have no unequal pupils, which would be a danger sign for now.
The blood sugar is 8.4 millimoles per liter.
Okay, it's 8.4, that's also normal. Do we have any, patient has not had any seizure, that's good. Any sensation, the patient is able to feel,
You
right?
can feel and has normal
Normal motor response. So in our disability assessment, the significant finding is that the GCS is at 12 out of 15 for moderate TBI. You've given the monitor.
Yes, I have given the money for.
We have to, could you continue monitoring and see if the pupils become unequal? That would be a danger sign, but for now, I think we go to our disability. We can proceed to our exposure. Okay, I have my shares here. I will start by exposing the patient.
When you expose the patient, he has tenderness in the right lower limb, there is swelling and deformity over the thigh.
Over the thigh. So this part of the right thigh is swollen,
Yes.
but there's no open injury.
There is no open injury, there is no laceration, but there is definite deformity, there is swelling
Okay.
and tenderness over the right thigh.
All right, yes, sorry, Sebo. So this indicates that the patient most likely has a femur fracture. All right, based on this femur fracture, could you start giving tranexamic acid? To pair 1 gram, there might be some internal bleeding because we can control that. In the meantime, there are no other
No other
injuries
deformity of the lower part of the limb
And then on the
deformity
left?
of the left.
on the left, okay?
TXA has been administered.
Well done, Rebecca. How about the upper limb? Any deformities?
No deformity of the upper limbs.
And no deformities on the head?
No
bruising.
bleeding, no bruising, no swelling.
There was bruising, there seemed to be bruising from the nose and the
Yeah,
ears.
he has bleeding from the ears, but also bleeding from the nose.
Okay, so that shows potential brain, that further confirms our potential brain injury. Is that okay? So based on our findings, so far, we see a patient who has a potential moderate traumatic brain injury. They has an elevated respiratory rate, so we have signs of respiratory distress, but stabilized on oxygen. Okay. No signs of shock at the moment. We've started maintenance fluid. We've also controlled for pain with IV paracetamol. We might need a stronger painkiller. So Rebecca, you might prepare IV fentanyl in case the team that comes to respond. And then we've seen the femur fracture, so we need to at least immobilize. So can we work together to immobilize the femur fracture? Okay. So he's gotten pain, so we're going to try and immobilize.
Oh, yeah, my leg.
Please bear with us. It's really, I know it's going to be uncomfortable,
My
but
leg.
it's going to be really helpful.
Oh, my leg.
So sorry. Okay, all right. Well done, Rebecca. Can we put this also? Make sure that the joint above, the one for the hip, and the joint below the knee, could you hold this, all right, is also immobilized. Well done. Put some sponges to reduce any pressure. Okay, good. And I'll start from the ankle. Could you hold this for me, please? All right. I'll do 1.
Oh, doctor,
Sorry.
pain.
Would you continue talking to the patient, Emma, to make sure that he's calm and let us know if the situation changes? And
Okay, you can keep calm. Doctors are working, please.
all right, well done, Emma. Good job. Okay, right, done a figure of 8. Okay, so we proceed. So sorry. We need to keep this. Okay, well done. Okay. Emma, also, once we're done, you could call for help. We might need to transfer this patient in, right, to Mulago. This patient might need to go to Mulago. Because of the traumatic brain injury, they will need to do a neurosurgical review. They will also need to do orthopedic review for this lower limb, and then CT scan. Sorry, and we can also give IV phenytoin for now, yes, to control the seizures. Okay. Yes. Good job.
We definitely need to refer this patient to Malabo National Referral. I'm going to call the regional emergency coordinator at the Masaka Regional Referral and see if we can arrange for us an ambulance to move this patient. Help me continue monitoring the patient. Let me make the call. Hello?
Hello, Rachel in the call and dispatch center. How can I help you?
Rachel, am I speaking to the regional emergency coordinator at the regional referral, Masaka?
Yes, you're speaking to Dr. Rachel, emergency region coordinator for Masaka region.
Yes, Rachel is speaking to Dr. Simon Tumusime at Masaka Emergency Unit.
Yes, Dr. Simon. How can I help you?
I'm calling you about a patient that we have. He's a 30-year-old border cyclist who was involved in a road traffic accident. The patient came in with multiple injuries, and I think we would like to move this patient to Malago National Referral Hospital.
Oh, okay, Dr. Simon. May I please know the patient's name and address?
So the patient is called Mukasa John. The patient is 30-year-old. He comes from Chavakuza Trading Center.
Oh, may I know whether the patient has any chronic illness?
No, the patient, from the history that we took, the patient has no any significant chronic illnesses and is not on any known medication previously.
Oh, may I know any intervention that has been done to the patient so far?
Yes, so the patient came in confused but able to maintain the airway. He was having a respiratory distress, so he's currently on oxygen. We definitely need to refer this patient to Malago National Referral. I'm going to call the regional emergency coordinator at the Masaka Regional Referral and see if we can arrange for us an ambulance to move this patient. Help me continue monitoring the patient. Let me make the call. Hello?
Hello, Rachel in the call and dispatch center. How can I help you?
Rachel, am I speaking to the the regional emergency coordinator at the regional referral, Masaka.
Yes, you're speaking to Dr. Rachel, emergency region coordinator for Masaka region.
Yes, Rachel is speaking to Dr. Simon Tumsime at Masaka Emergency Unit.
Yes, Dr. Simon, how can I help you?
I'm calling you about a patient that we have. He's a 30-year-old border cyclist who was involved in a road traffic accident. The patient came in with multiple injuries, and I think we would like to move this patient to Malago National Referral Hospital.
Oh, okay, Dr. Simon, may I please know the patient's name and address?
So the patient is called Mukasa John. The patient is 30-year-old. He comes from Chavakuza Trading Center.
Oh, may I know whether the patient has any chronic illness?
No, the patient, from the history that we took, the patient has no any significant chronic illnesses and is not on any known medication previously.
Oh, may I know any intervention that has been done to the patient so far?
Yes, so the patient came in confused but able to maintain the airway. He was having a respiratory distress, so he's currently on oxygen with a non-rebreather mask. He had no signs of shock, but we started 500 mils of normal saline for the maintenance fluid. He has femur fracture on the right. We've mobilized that femur fracture, and we've also put a cervical collar to help with cervical spine immobilization. We've also given mannitol and started phenitol for prophylaxis against anti-seizure, and also given IV paracetamol for the pain medication. So the patient is, the patient has a traumatic brain injury, potentially with, we've observed some bleeding from the nose and the ears. We also suspect some potential cervical spine involvement. He has a right femur fracture. Those are so far the injuries that we have observed from our assessment.
Oh, Dr. Simon, please may I know any anticipated complications during the transfer?
Yes, so based on the current level of consciousness on the GCS, the patient is currently 12 out of 15 on the GCS. And so we suspect the patient's level of consciousness might deteriorate further, and the patient might have a seizure or conversion. So I will have to warn the team to watch out for that. Also, because of that, we will also want, there's also potential risk of vomiting and aspiration. And I think the patient might need, in case the level of consciousness goes further down, the patient might need to, the airway might need to be protected. We've not ruled, currently from our assessment, the patient has no signs of shock, but that has to be monitored. And I think the femur fracture is stable, but continuous monitoring, and maybe we've started tranexamic acid to 1 gram, but I think we will need to monitor and see if there are any signs of shock. So those are the things that I'm currently thinking about.
Okay, thank you, Dr. Simon. Please, can you share with me the patient's current vitals?
So from our monitor and from our assessment, the vitals, the respiratory rate is currently 25. The SpO2 is 98 on a non-rebreather mask, 10 liters. The pulse rate is 110. The BP is 100 out of 60. And then the temperature is 36.8.
Oh, thank you, Dr. Simon. This is a critical patient, and I think you will need a type B ambulance.
Yes.
So I'm going to communicate with the Malago emergency team and the ambulance team, and then I revert back to you.
Okay.
But one more thing before you log off the call. May I please re-echo what you have told me so that I be sure that I have not left out anything? You said the patient is called Mukasa John. He's a 30-year-old male from Chavakuza.
Yes.
He's a multiple polytrauma injured patient.
Yes.
With no any comorbidities. He's currently having a femur fracture which is immobilized, cervical collar in situ, and he has 1 liter of IV fluids running. You've given seizure prophylaxis, osmotherapy, analgesia, 1 gram of paracetamol, and tranexamic acid running. So you're referring for neurosurgeon review and brain CT scan. That is further investigation.
Yes, don't forget, Rachel, that we've given 1 gram of tranexamic acid because of our.
I'll revert you. Hello, Andrew. How are you?
Hello, Dr. Rachel. I'm fine.
We have a patient
Yes.
at Masaka Regional Referral Emergency Unit. He's
Okay, we
called
have a patient.
Mukasa John. He's a 30-year-old male from
Okay.
Chabakuza. He's
Okay.
a polytrauma patient with no chronic illness.
Yes.
They want us to move the patient to Mulago for neuro review
Okay.
and further investigation and care.
Mm.
The patient has injury, they're suspecting cervical injury, he has a
Cervical
femur
injury.
fracture and traumatic brain injury. Currently,
brain
the femur
injury.
fracture is immobilized, has a cervical collar in situ.
Okay.
He has been given osmotherapy mannitol 20 grams. He has been given phentoin for seizure prophylaxis and some 1 liter of normosaline he's
Okay.
running. The suspected complication during transfer, they are anticipating further deterioration due to shock, and maybe the patient might get seizures.
Okay.
Current vitals for the patient, the respiratory rate is 22 breaths per minute. The SpO2 is 98 on 10 liters of oxygen.
Okay.
The pulse rate is 100 beats per minute and a BP of 110/60.
Okay.
So I think you need to prepare and notify your ambulance driver to go and evacuate this patient.
Okay.
I don't think it's going to be a complicated case for you.
Okay.
Okay, thanks.
Okay. Thank you so much, Dr. Rachel. Joseph, we have right now, we have been dispatched to go to Masaka Regional Referral Hospital. We have an emergency. Let's get the driver, we get ready to go. I'll brief you entirely as we set off.
Okay, driver, Masaka Regional Referral, okay.
Good morning, doctor.
Good morning.
My name is Andrew, is my colleague Joseph. We're dispatched from Masaka Call and Dispatch Center to come here and pick a 30-year-old male, John, who was involved in a road traffic accident in Faro to Mulago Hospital.
All right. Good morning, Andrew. Good morning, Joseph.
Good morning.
Yes. Yes, Andrew. This is a 30-year-old male. His name is Mukasa John. The patient is sustained a road traffic accident with multiple injuries, with a potential traumatic brain injury and a right femur fracture. On arrival, the patient was confused, but the airway was still patent. He had no signs of shock with a normal capillary fill of 1 second. His pulse rate was around 110 and the volume was good. His blood pressure has been 100/60. The pupils are equal and reactive to light. His blood glucose level is currently 8 millimoles per liter. He has not sustained any seizure or convulsion since he arrived. On exposure, his temperature was 36.8 on arrival. Currently, it's still the same. He has a right femur fracture, which we have immobilized. He had no other external bleeding, apart from bleeding from the ears and the nose, and then no other bleeding outside. On the, we checked the GCS. The GCS is currently 12 out of 15. We've immobilized the cervical spine. We've started him on oxygen. He's on non-rebreather. We've also given 500 mils of normal saline for maintenance, but he had no signs of shock. I think this patient would benefit from a CT scan, but also would like for the team at Mulago to have an orthopedic review as well as a neurosurgery review.
Yeah, okay, that's great. What are the current vitals right now?
You will see on the transfer form, but the current vitals are currently, the respiratory rate is 20 breaths per minute. The SpO2 is 98 with a non-rebreather mask. The blood pressure, the pulse rate is around 110, as you can see. The blood pressure is 100/60, and the temperature is 36.8.
This journey is going to take us about 6 hours. What medications might we need to give en route as we go that you're prepared for us for this patient?
Because of the level of consciousness, the current GCS being 12 out of 15, we've given IV phenytoin prophylactic to manage the seizures prophylactically. We've also given mannitol for the traumatic brain injury, and given IV paracetamol for the pain, and some antibiotics. However, I suspect if the patient's situation deteriorates further, he might have another seizure, and we might need to give, you might need to control the seizure, as well as you might need to give another stronger painkiller. So I've prepared IV fentanyl for you here. Let me get it for you. Yes, this is IV fentanyl.
Just a small question for the doctor. You mentioned about the possible convulsions. Could you also be kind to give us some diazepam?
Thank you, Joseph. That's a good point. I did prepare also some IV diazepam. I think you might need it in case the patient has another seizure, all right? So you can have this.
Okay, thank you. Let's prepare and move the patient.
Okay, so I will help you move this patient. I spoke with Dr. Rebecca at the emergency unit, Malago National Referral. She's been notified. I think she told me she's ready to receive the patient. And then you let me know once you've handed over this patient.
Andrew. Why don't you increase the volume? Let me go ahead. And no sound from you now. Someone told us.
Okay, so
But also my thing is connected.
It's okay. It's okay. It's okay. Don't say the sound cable, that's why. It's sound cable.
What step?
It's close. There's no sound. Wait.
Alright, think we're done, yes? Right now with the ambulance. The transit, the ambulance. Patient is being transported to Lago Hospital, right now in Lago. Being transported by Andrew as well as Joseph. So Andrew and Joseph actually Lago before the accident and deteriorate. About 1 hour away from Lago Hospital and the patient starts vomiting.
Yes. Richard. Has vomited and went into the distress.
Okay,
Increase the oxygen flow and our pulse rate is 142. The blood pressure was 100.
what's the pulse again? What's the pulse again?
Our pulse 142,
Okay, it has gone up.
and then our blood pressure is 106/100.
What happened in the ambulance? What happened in the ambulance?
The patient vomited
Okay,
and then increased the oxygen flow.
okay. When you listen to the chest,
And the patient had problems by lung.
oh dear, the patient must have aspirated. How much oxygen is the patient on?
Previously, it was on 10 liters and just increased to 50 liters of lung.
Okay, so now we're at 15 liters. Is he breathing very fast? What's the respiratory rate?
The respiratory rate is 28 minutes per minute.
Okay, all right. So let's maintain him on oxygen. 15 liters is fine. He has a non-rebreather mask, so maintain that. And for the blood pressure, you said the blood pressure was how high? You said 160/100?
160/100.
And the pulse?
The pulse is 100.
Okay, okay. So now I think we need to monitor that, but let's increase the flow of the mannitol. I was told the patient was on mannitol.
Yes, the patient was on man.
Okay, so please increase the flow of mannitol, but also what pain medication are you on?
When we're coming, they gave us fentanyl.
What did he come, when you came from Masaka, what medication had he been given? Okay. Okay. Okay, Andrew, thank you so much. What you do, let's give the patient 50 micrograms of fentanyl, give it slowly, and then we monitor the pulse rate. It could be pain that's causing his pulse to go up. So please give him 50 mics of fentanyl. Yes, and then you can call me in case of anything. The other thing is maintain him on fluids, and let's get here as fast as possible. The neuro team is waiting for the patient.
Driver, slowly go through the bump slowly. Joseph, I have put Dr. Rebecca and she has said to maintain our patient with high flow protein. That's slowly. Okay, and keep monitoring. Can we also elevate the bed again now that we are out of safety? Okay, so as we proceed,
Okay.
so I will go to disability.
All right. So in disability, the patient.
Hello, what is our MBPU is a GCS.
So at FBPU, who only responds to pain.
Only responds
to pain.
Okay, so and pupillary reaction.
He reacts, his pupils are equal and reactive to light.
Equal and reactive to light, and RBS.
His blood sugar is 8.3 millimoles per liter.
8.3 millimoles. We are safe. Okay.
However, your patient now starts convulsing.
Okay, so the control.
Yes.
The patient is convulsing. Have you given the fentanyl already?
Yes, we've given the fentanyl.
Okay, let's give a dose of benzodiazepam.
So, Joseph.
Okay.
Dr. Simon had prepared for us the diazepam.
Okay.
We are going to give a dose.
All right.
The patient is still convulsing.
So the patient is still convulsing even after the first dose?
Even after the first dose, is still convulsing.
Okay, control. And we give a second dose?
Okay, we had the second dose.
Yes. Perfect. So let's try and see if that will stop the convulsions.
Okay, after the second dose of diazepam, the patient stops convulsing.
Oh, thank God. Driver, how long?
You're about 15 minutes away from Molago.
15 minutes away from Lago. So our airway,
Your airway is now clear.
Breathing, we are still at 15 liters. Okay, and all right, so we need to call the doctor again and tell them about the convulsions and what has changed. Yeah, please call.
Hello?
Hello?
This is Dr. Rebecca.
Yes, Dr. Rebecca.
Is this the team again from Masaka?
Yes, this is the team from
I've been waiting for you. We're here at Casualty. Where's the patient?
Yes, every person will come in our patient convulsing.
Okay.
And we gave the first dose, the diazepam, and the convulsion did go. Then we added the second dose of the diazepam and the convulsion.
Okay, did you check the blood sugar?
Check the blood sugar and it was 8.3.
Okay, okay. Thank you for your quick response. Is the patient on phenytoin?
Yes, the patient is on phenytoin.
Okay, okay, that's good because the phenytoin will prevent any further seizures. All right, so thank you for the good work. Please get here as soon as possible. We're waiting for the patient. 5 minutes? Okay, we are waiting for you.
Okay, so Andrew, let's see that we have we also prepare for the handover. Okay. So we will also take the last vitals, right? So we will repeat the airway current feed, okay? The page. Okay. Hope that is safe for the head. OBA is still in situ. Intact, it's breathing.
Good afternoon, Doctor.
Good afternoon.
My name is Joseph Senkumba. With my colleague here, Okirol Andrew, we are from Masaka ambulance team. With us is a 30-year-old Mukasa John who got involved in a road traffic accident, suffered a severe TBI and with a fracture femur. He was stabilized. Yes?
Yes.
He was stabilized at Masaka. We found him on oxygen. They had given him some mannitol and managing the pain with paracetamol. And they called us for transport. We maintained the treatment, but while en route, the patient deteriorated, started vomiting, had like 2 episodes of convulsions, and went into respiratory distress. We suctioned him, he started an OPA, continued with oxygen, and also gave him some fentanyl. We recommend that John gets an immediate CT scan, gets a neurosurgical review, and also an orthopedic review and emergency resuscitation. Yeah, I have this.
How many doses of diazepam did you give?
2 doses.
You said that he was confused.
Yes, yes.
What time did you give the fentanyl?
That was around 12 p.m.
Yes.
Thank you very much. We shall take over from here.
Thank you very much.
All right, team, welcome back from that. And everyone who has any questions, please put them in the chat. Dr. Anna Kaguna is there to respond to your questions. As you have all seen, we have been managing a trauma patient from Masaka Regional Referral Hospital. And I hope you enjoyed this learning session. The objectives for this session are we want to highlight the importance of pre-referral communication, pre-referral stabilization. We also want to highlight the importance of your primary survey and stabilization for emergency patients. And right now we're going to have the debrief session. The whole team is here with me, and we're going to go around the room to discuss the case, and then we shall have the discussion from there. So team, thank you very much for resuscitating the patient. Well done. The patient arrived at Mulago Hospital. I will start off with Dr. Simon. Dr. Simon, how did the scenario go?
I think the scenario went well. We received a patient who had just been in a traumatic accident with a moderate traumatic brain injury with other multiple injuries, and we managed to stabilize him with my team and call the regional emergency coordinator to dispatch an ambulance, which she did, and then we received the team that came, handed over a patient in a very stable condition.
Okay, and then I move back to the dispatcher. Rachel, how did that go? Please give us the positives. What went well?
It went well. The medical officer at Masaka knew the patient very well, and they had stabilized the patient very well. So I didn't have to give so much advice to the care they had been provided to the patient, other than alerting my team to quickly go and pick the patient. The patient wasn't that critical that I needed to escalate care maybe to the end of the Human and Dispatch Center. We seamlessly just worked with my ambulance team and moved the patient.
Okay, and now to the pre-hospital team, the ambulance team, Andrew and Joseph. What went well in this case? I'll start with Andrew.
Yes, thank you so much, and thank you, listeners, who are listening to us. We want to start with what went well. I will give some for Joseph as well. So basically, I'll mention maybe 2 or 3 very important things that went well is that one, there was constant communication and looping in the receiving facilities instantly whenever there is any unusual or anything that was happening to the patient. For example, this patient started deteriorating as we're moving and not wait any single moment, we would alert the receiving facility so that again, they also guide us. And then whatever interventions we are doing, they are aware and they are able to tell us what to do. Then the other one also, we work together as a team with Joseph. As Joseph is assessing, I intervene, and if he needs to communicate the receiving facility to instruct me to make that communication and give him the feedback, then we manage the patient accordingly.
Okay, Joseph, what went well?
I think for this scenario, there was cross-room communication, non-technical skills were shown as it's important for patient management. When Andrew was doing something, I have instructed him, for example, putting an OPA. He would tell me, Joseph, the OPA is in situ. So that's very important that you don't forget things. Also, I thank Masaka team and the doctors who were with the patient, they prepared for us. We did not look like lost sheep. Inside the ambulance, they had prepared us some meds that we would use if the patient convulses, so we were prepared. And the other thing is that the ambulance workspace was good for this one. I know that we have very many types of ambulances, but for this particular one, they could stand, we could move, there is plenty of space, so that worked well.
All right, and over to you, Dr. Rebecca, who received the patient and received a call. What went well in this scenario?
I must say that communication was really, really good. The ambulance team was able to detect any significant decline in the patient's condition, communicate to us, the receiving teams, that can help and guide them to intervene accordingly, which again helps improve the prognosis of the patient and also help us as a receiving team to understand what kind of patient is being brought, what interventions have been made so that we can properly prepare to receive this patient and give the appropriate care.
Right, thank you. So I noticed that at all stages of care, the primary survey was done. Even at Masaka, and even in the ambulance, you went through systematically A, B, C, D, E. How important is it to ensure that you go through your primary assessment at every phase of patient care? And I'm going to ask Joseph here, why is it very important?
Thank you very much. I do not know how people used to treat patients before APCD. I really don't know. Because I feel that when you do that, then you can easily know what will kill the patient first. Of course, the patient can have a lot of things, like ours, who was a polytrauma patient. You can easily run to the fracture and spend all your time, and something small as the airways blocked will kill the patient first. So it's important because ABCDE will give you what kills the patient first, and also gives you a systematic approach to doing things, how you would start anyway. For example, how would you start it on a patient who is just sleeping there? Do I start with the legs? I start with, but the ABCDE gives you a systematic approach that starts with the head, starts with the airway, go to breathing, and you know when you correct one of them, you have corrected many of the other things. So it's really important for healthcare workers, ambulance teams to keep this systematic approach. If you forget it, then you have forgotten so many things about this person.
Over to you, Simon.
Yes.
You made the decision to refer the patient from Masaka to Molabo.
Yeah.
Why did you make that decision? And what are some of the things about this patient that could have guided your decision-making process?
Yes, so as we reviewed the patient, we clearly noticed that our most significant injury or most significant presentation was the head trauma, traumatic brain injury. We also recognize the femur fracture, but we know that Masaka could have stabilized potentially the femur fracture. We have a team here that could have done that. But for the traumatic brain injury, I believe the national referral has the neurosurgeons and they might need to review. So our recommendations or our next steps guided our referral process. we believe that the patient will benefit from a CT scan, a brain CT scan, and then definitely a neurosurgical review, and obviously an orthopedic review as well. And so when we made that decision, it was really mainly to seek out those specialized services which are present at the national referral.
So team online, referral is part of patient care. Please know your limitations in regards to your scope of practice in terms of human resource, in terms of supplies, in terms of equipment. The referral process is meant to support you and guide you as you make your decisions to manage the patients. Don't hold on to patients that you know you cannot manage. If you know that the patient needs specialized care, please refer the patient urgently. Dr. Rebecca, you received a call from the ambulance team. Take us through your thought process as you received the call. What was happening to the patient? There were two key things that happened. Patient had vomited, but also the patient's hemodynamic status had changed and then later convulsed. Just talk us through what was going through your mind at that time.
So as you can see from the scenario that we just had, when they called in, one of the key things they noted was that the patient's hemodynamic status had changed and the patient was starting to breathe a certain way. So and had also convulsed. So the mere fact that they had convulsed, they have a history of being managed for TBI, they have convulsed, most likely they have aspirated. So that would explain why their breathing had changed. Traumatic brain injury, with traumatic brain injury, you do expect this patient to be at risk for increased ICP or increased intracranial pressure, which could also lead to convulsions. So the mere fact that they called in and you guided them on what therapy to give to continue the suctioning, put an OPA suction, protect the airway, continue with oxygen management, and also give anticonvulsants, the diazepam that they gave, the 2 doses that they gave for the 2 convulsions that they had. You could think of also hypoglycemia, which could also be responsible for the convulsions, of which they gave, I think, some glucose as well. Yes. And also the pain that the patient could have had because of the pain could have also been the reason why their pulse rate was elevated. So we advise them to also give them some pain medication. The fentanyl that the referral team had prepared came in handy, and which was administered.
All right, thank you, team. I want to open the chat and open to our colleagues online. What went well with this scenario? Please raise up your hand. Please put a comment to give us the positives first. And let us know what went well with this scenario. Any hands up? Yes, Dr. Alon. Dr. Alon Nahabwe, please unmute and tell us what went well with this scenario. Dr. Nahabwe, please, could you speak? Your hand is up. Dr. Nahabwe, you have unmuted, but we can't hear you. Anyone else online who wants to comment about what went well? Dr. Anna, any comments about what went well?
Okay, this is Dr. Mahad, EM resident.
Yes, Dr. Mahad, I recognize the voice. What went well?
So I think what I realized that the communication from the team was very, very professional. Like in every step, the team was communicating about what's the level of the patient, and I think that's helped a lot to safely arrive the patient to the Mulago National Referral Hospital.
Yes, so communication is very important. So the non-technical skills where Joseph talked about closed-loop communication, but also pre-referral and inter-facility communication. And there is another hand up. We have Castro Emao. Castro Emao, your hand is up.
Yes, thank you very much. First of all, I would like to commend the organizers because I think every other day we are getting better. at our eco sessions. Today, the demonstrations were particularly very important for us. With EMS, it's really the hands-on. Sometimes they need to show people how to do things. But the take home for me is the teamwork, really. Right from the Masaka Regional Referral Hospital, you could actually see that the team were all working in unison. We were agreeing at every step together. They were discussing everything together. And this really showed that they had the patient's best interest at the forefront. And then when you look at the debrief by the team that was receiving the patient at Masaka, vis-a-vis the team that was taking over, you could actually see that all the information was actually provided. Nothing was left out. And that was very, very important for them to actually make decisions during transit. That's all from me. Thank you. Over.
Thank you, Dr. Castro. You have highlighted the importance of communication. Our friends and our colleagues, when you're referring a patient, please document. Please don't be afraid to tell us what you have done for the patient. It's very important because, like Castro has mentioned, it's about the patient management and patient care. So the referral note is very important, but also pre-referral communication is also very important for this patient. Okay, anyone else online who has a hand up and wants to mention what went well before we went to what did not go well? Okay, so preparedness of the ambulance, yes, very important. Stephen Odoch, you have the mic, please unmute and tell us what went well.
Okay,
Stephen
thank you everyone.
Odoch.
Thank you everyone who attended this session. I'm Stephen Odoch, an enrolled nurse. What I saw that went well was the effective communication. And then another thing was there was a lot of teamwork. And then the person in the ambulance was monitoring the patient closely. The only thing about communication, I think there was an error when they were talking to the communication people at the Masaka, where there was a lot of interruption. The referring physician did not give we are not giving time. So you will find someone is giving this information and then is asking for vitals. That is what went wrong. And then another thing is our patient aspirated. Probably, I don't know whether there's no sanction machine in the ambulance, but I don't know why the patient aspirated. Thank you. But everything was okay.
Right. So one last comment from Eric before I come back to the team. So Eric and then Nwanga Badan. So Eric first.
Thank you very much, Doctor. Eric from IM Rwanda Emergency Care System. And I just want, first of all, say thank you for incorporating the emergency medical services or ambulance service into the scenario, which is more important because sometimes the ambulance teams become burden to the emergency department teams. So working together is another value to the patient outcome. Thank you very much for that. I want to say what is going well. I think first is the collaboration between the EMS team and the emergency department team. That was good. And I think the rope communication between the two teams was good also. The EMS team was ready with all equipment and enough space in the ARS ambulance. And I think at each time, they ask driver how many time remaining. The driver also was part of the team, which is very good and give a confidence to that part of EMS, sometimes not considered. At arrival on the hospital, I think they have been well received.
Eric, we've lost you there. Eric, we've lost you from Rwanda. I think Nwagaba, we shall hear from you and then we can come back to the room. I'm going to ask Ali and Abel to put your comments in the chat. So, Nwagaba Dan, please speak.
Okay, thank you so much, Tim. We really appreciate, and I'm sure we have benefited from this. So one, I'm very happy that we have a system in place. At least we have an emergency system in place. What went well, I like the fact that we have different stations that respond in time. You are able to call the ambulance station and they responded in time. Able to call where you are referring and they responded in time. Like they're able to pick up the phone call and give you a feedback. What was more beautiful was the fact that the referring site was able to provide some emergency drugs to the ambulance team to help them in case of something that happens. Because what we have seen commonly, people just get someone on an ambulance and that is it. They don't care what happens during transit and everything. But the fact that they were able to anticipate things that can happen on the way and they provided them with emergency drugs, that was really nice. Thank you so much.
Thank you so much. So back to the room here. Tim, we all know that we are in the process of developing an EMS system in the country. What we've demonstrated is an ideal situation. We're all in the space of emergency care in our different capacities. What do you think we can do better, especially in terms of referral, in terms of transit, in terms of emergency resuscitation for our patients? So I'll go around the room. I'll start with Rachel. What can we do better in terms of dispatch?
Yeah, thank you so much, Dr. Doreen, and thank you so much, our online viewers. As you've heard, you have been emphasizing the importance of those with communication. So I'm going to talk about communication. Yes, I know as we were here, Ministry has tried, we were building the system, and Ministry has tried to bypass the ambulances, to put some form of call and dispatch. But as you know, we don't have a fit-or line for people to communicate. However, that will not stop us to communicate when we are referring patients, because now we are in a global village. We have social media. We know who is working in Molabo. We know who is working in Masaka. So my outcry is to call on the public, the health workers, to communicate. Get that phone and call the person where you're referring to.
Yeah. Okay. Thank you, Rachel. Our ambulance team, in your practice, what do you think we can do better in terms of ambulance transportation and emergency resuscitation in transit? I'll start with Anne.
Thank you so much, Dr. Doreen, and our listeners in. Happy to hear from Rwanda and other countries who could be there. Thank you. I think now this is generically, not specific to this case that we move, but largely EMS we support in patient care in terms of moving them from one facility to another. And that all starts with preparation. So largely, most times you have to prepare for our patients. And each time you're preparing, you have to anticipate. So you weigh the risks and the benefits first for the transfer, and then you prepare as per that analysis. So we anticipate, for example, this case, this patient had this was a TBI patient, a polytrauma patient. So we anticipate what we expect. And this has to be a discussion between the team that is going to refer, given new resources at your disposal, and the facility that is referring the patient. Because again, as we saw, they can also sometimes support with some of the things that you may not have. For example, this patient needs some medicines like opioids, which are very controlled and they may not be stocked in the ambulance. So they can support in that way. And then also the other is, Dr. Rachel just talked about communication. And I want to marry that with what Dr. Rachel said, document each and everything. So the referral process also involves giving care to patients. So as we move the patients en route to the facility, we have to give them care as we transport the patients, not just sitting at the front, something that large us in EMS, I see us doing it, we do it quite a lot. sit at the front, the driver, start conversing from the front, and the patient is at the back. So that is not something that we have to do. So you have to give care input as you move to the next facility. So in this case also, in case anything happens, perhaps the patient deteriorates, which that can happen. Sometimes, like for this movement, especially, it was a long distance. So we're going to be with this patient for 6 hours. We are limited by knowledge, resources, and equipment. However, we can borrow from both the referring and the receiving facility. If they are not in that loop, we have the EMS escalation protocols in place, whereby we have to go back to our dispatch, and then we have Dr. Rachel here, who is now called our dispatch. We call them, then they give us guidance on what we can do en route as we move the patient. So I'll leave it at that for my colleague also to add, and also to say what we need to do as we go.
So I would say Mukasa John, our patient today, is a planned patient. He was lucky to fall in the hands of people, health workers who have been trained and who have the passion and who follow the guidelines. What I see that we need to do more is to train more people. There are so many ambulances moving on the road, but I doubt if what we just did is what happens in all of those ambulances that we see moving. So if you are a nurse or a healthcare worker on this call, and you love putting patients behind and sit in front, shame on you. Shame on you, because our work is actually inside there where you have seen us work. It is our office, and you have to keep reassessing the patient, keep your eyes onto the patient, anticipating what is going to happen next. So this is an opportunity for me to tell health workers that please, when you pick patients, the office, much of the work is behind. Please stop sitting in front of the vehicles and start treating patients in the mirror, looking back. So the other thing is that for this patient, TBI, and all the other complications, if Masaka had some physician who is free, would be nice to go with. But in the case where there are not so many people, we managed to go through, but like he said, we are also lucky to make a call along Masaka Road, and maybe the caller dispatch at the doctor in Mulago was not busy, and they kept picking and they kept supporting. If we did not have that kind of support, we would be limited. Maybe the outcome would be very different because we are limited. Some of the big cases might need special people. That's why I think we are training emergency physicians. So I will say that let's train, and then also equipment. Yeah, we will do better than the cardboards. Maybe we try to use the cardboards because it is what available. But if we plan, we procure some of these emergency things, attraction would work. I think this patient would feel more comfortable. And also the long transfer could have also needed maybe extra other sort of movement devices. The ambulance, preferably not just an ambulance coach. Thank you.
Thank you, Joseph. Over to you, Simon. In your experience, we've had challenges with patients coming from referred facilities.
Yeah.
What do you think these referring facilities can do better in terms of emergency resuscitation for critically ill patients?
I think that's a wonderful question, and we can borrow a lot of lessons from what we've already shared. What is very clear is that I know that everyone was commending the teamwork that happened right away from the referral facility to the transfer and then to the receiving facility. But there is no teamwork without individual work. You know, it's really important that every individual knows what they're doing. I believe in the case that we demonstrated in our scenario, you could see that everyone was familiar with the next step of patient management. That I think speaks to what Joseph has already mentioned in terms of like training and being fully equipped and knowing the necessary skills that you're supposed to do as an individual so that you can play a very big part within the team, right? And also it speaks to the universal language that we speak in emergency care, which I like to commend in that right away from the referring facility to the receiving facility, we are all speaking the same language. I know the language starts with A, B, C, D, E, which is the primary survey, but everything is centered around that. And because there is a commonality in language, it is easy for everyone to be able to pick up and then manage and proceed with patient care. In most of the facilities that I think we have, the knowledge gaps are still evident. And I think if as with the opportunity that Seed Global presents with the eco sessions, I think those gaps are currently being plugged. But I would also encourage people on this platform to look out for even more in-person skills training that can further equip them with their unique and individual skills so that they can be a big part of the teamwork that's needed. Then I think the other thing that I would say, there are resources besides training that sort of help with management. And one of those is there's something called a transfer checklist, which is very important. So for example, me at Masaka, before I make the decision to transfer the patient, that transfer checklist allows me to make sure that I've checked other things and I've made the right decision, you know? So we can utilize such resources, use referral forms and protocols, but also I think my take-home message is that I'll just urge all the individuals to have the necessary skills because it doesn't, I think what we demonstrated is that regardless of the resources that you have, it's possible to manage a traumatic brain injury. We didn't use very hard and sophisticated equipment and were able to deliver the care that is standard. And I believe that everyone here, regardless of their place, I know there might be some missing equipment, but I believe they can do a great job if given the necessary knowledge and training. So I think that would be my take home. And thank you everyone for joining in. All the best.
Thank you, Dr. Simon. Dr. Rebecca, in your experience at Mulago Hospital, which is the National Referral Hospital, what have been some of the challenges in regards to referred patients that are coming into the accident and emergency? And what message would you give to health workers at different referring sites in order to improve patient outcomes?
Thank you so much for that. I think from this scenario, it's quite evident that pre-hospital care bears a huge bearing on a patient's clinical management and their outcome. Imagine if this patient from enrolled to Mulago Hospital had a convulsion, aspirated. By the time they come and arrive at Mulago Hospital, they'll have added complications that will worsen their prognosis. So it's very important that the referring team, the ambulance team, do a good job, communicate to the receiving facility, to also help them be able to properly prepare to receive this patient. The receiving facility will be able to mobilize resources, both in human resources and supplies, in order to help this patient. Get a brain CT scan, get a team to help this patient, whether it's neuro, orthopedics, surgery, more EM physicians and nurses, an entire team to properly intervene in this patient's care. So communication is very important. And calling for help. The ambulance team was knowledgeable and able to detect clinical deterioration in this patient, and were able to call the receiving facility for help. And the receiving facility, the doctor was able to guide and intervene and stop any other further complications that this patient would have gotten beforehand. And therefore, by the time the patient arrived, they were in a better position than they could have come if they were not intervening.
All right, thank you, Dr. Rebecca. it's very important that one, we recognize the importance of pre-hospital care. We have pre-hospital care providers in Uganda, both private and government. And we want to applaud you for the work that you're doing. We want to acknowledge Zia, Angelina facility. They provided the amazing ambulance that we saw here, but it goes to show you how far ambulance services have come. It goes to show you how far partnerships have come. We now have collaborations with private healthcare providers, and government is doing a lot in terms of ambulance services. We now have regional emergency coordinators, we have dispatchers, we have ambulances, and I'm going to ask Dr. Rachel to give us a brief talk in regards to the EMS system in the country. Some of you don't even know who your REC is. Some of you don't even know who to call when you need an ambulance. Some of you don't even know that ambulance services, government ambulance services, are free of charge. And you don't even know that in your facility, you can call for an ambulance to help you transport a patient from point A to point B. So I'm going to ask Dr. Rachel to give us a small talk in regards to how the government ambulance services work and how the RECs coordinate ambulance transfers in the country. So Dr. Rachel, over to you.
Thank you so much, Dr. Doreen. Thank you so much, our online viewers. Yes, we'll start by appreciating Ministry of Health that established the National Emergency Medical Services. That is in 2017, and it's being led by our Commissioner, Dr. J.B. John Baptist Wanyaye. We appreciate, because before we didn't have. So the National Emergency Medical Services has been able to put into place and call a dispatch system that is organized in 2 tiers. We have the National Emergency Medical Service Call and Dispatch Center, and that is stationed at Nakuru. And we have call takers and dispatchers and ambulances, different ambulance categories that are stationed there to serve Kampala metropolitan area, though they can also give services in case support is needed to other regions. So as I say that the call and dispatch system is organized in 2 tiers, the national one, then we have the regional ones. As Dr. Doreen has been talking about the REC, the regional emergency coordinators. So each region, as we have the 16 regional referral hospitals, so that's how it's organized. We have each region as the regional emergency coordinator, and different contacts are being flashed on your screens. You can see who is your REC and which number to call. The government, the Ministry of Health, has a plan to make sure that all those regions, they have fully functioning call and dispatch centers. However, that has not, some region has not yet acted. So what is happening currently? We have the National Call and Dispatch Center in Nakuru. We have some regions that, like Masaka, they have a call and dispatch center in place. Alua is still in pipeline. They are constructing. I think the project is about completion. And also Mbarara, the project is about completion. And other regions like Bulu, Jinja, and other regions, the system is going to move. They will also get as funds available, as guided by the Ministry of Health. So as you see, those are the numbers that are flashed on your screen. Those are the contacts that you should call in case you have an emergency. Not only that, Ministry of Health and the Emergency Medical Services has in plan to functionize the toll-free number of that you could call on to get the ambulance services, and it will either be 911 or 912 as you are guided by the UCC's ministry. I will also tackle the question of whether these ambulances, ministry ambulances, are free or they are for pay. Ministry ambulances are free of charge. While we appreciate that Ministry of Health has been able to provide fuel to these ambulances, though not all the time we have fuel, we have challenges. And I love how different regions have come out to help the system by organizing within themselves to collect some small funds to support, to help the ministry support and see whether this system could continue running. Yeah, that's in summary that I can talk about.
Thank you. Thank you so much, Dr. Rachel. I'm going to ask Dr. Anna Kaguna. There were some questions that were in the chat and she's been answering them. Dr. Anna, do you have any comments for us online? Some of the questions that you want to re-echo to the rest of the team? Dr. Anna?
Thank you, team. Yes, over here. Yes, thank you, team. I think you've done a wonderful job. Most of the questions have been well attempted to. Maybe what has stood out often has been what are the protocols for in the event that I recognize a deteriorating patient, what protocol should I follow? And then the other was on the issue of the ambulances, which has been addressed very well by Dr. Rachel. The third question has been on the medications that we chose to use for our patient. Why did we give tranexamic acid when there was no visible bleeding for this patient? Why did we choose mannitol instead of hypertonic saline? Why did we give diazepam instead of phenytoin? Yes. So why did we give diazepam and phenytoin at the same time? That was the question. Those are the questions that stood out and came out often.
All right, thank you, Dr. Anna. I'm going to request the team to give their parting messages for this session. I will start off with Dr. Rebecca. What is your take-home message?
Communication, communication, and communication, and great team. These are my take-homes for today.
Right. Dr. Simon, take-home message.
I think getting skilled in the primary survey, getting the necessary skills to be able to recognize and offer timely support for any life-threatening injuries. That is my take-home.
All right. Joseph, take-home message.
Emergency medical services is a chain of things, the pillar of things right from the community where we need to recognize emergencies. Usually communication or call and dispatch and people in the community being able to give some first aid, and then the ambulance service, emergency services. So all those pillars should be worked on. And if you are here on this call and you belong somewhere in the pillar, please do your job, because when you skip your job, then the patient will not make it. Finally, as a head of a training institution, approved, I would encourage you to come to our center for training, right from advanced life support. For example, this case, TBI, is part of the cases that we do in ITLS and so many other courses. We offer those courses monthly by monthly, and some of them quarterly. I can give details whenever you need it. You can also find the information on our website, Association of Ambulance Professionals. Thank you, Sid. Thank you, Ministry of Health. Thank you, Zia Angelina. I am happy, was happy all the time working in your ambulance. You did a great job with equipment.
Thank you, Joseph. Over to you, Andrew. Take-home message.
Thank you so much. My take-home message is, each time we're moving patients in the ambulance, that's why it's called a patient cabin, and work on patients in the ambulance. So you have to sit at the back with your patient, and you care for your patients, not sitting at the front. And then also the other is documentation, and this is what Dr. Abdul also mentioned earlier on. Documentation is very important. So we document whatever we do, whatever you see, and also I encourage you to document anything wrong you've done. That is what most times people will not document. If they do something wrong, they want to document it, but for us, we encourage you really to document whatever, even if it's a mistake, just document or report it to whoever is supervising or whoever is going to receive the patient next. And then the other is in terms of patient care is most times we are limited in the EMS in terms of professional, in terms of what our profession can, the package you can give the patient. The patient may require advanced management. So in this case, before you move a patient, you weigh the risk and the benefit, the transfer, and anticipate also, like we did for this case, what you need to prepare for the patient. But also, if you require to move with an expert, and for us in EMS, we have the emergency physicians in this case, and you feel that this patient cannot move without our physicians on board, then there is no business doing this patient, otherwise the outcomes wouldn't be good. Thank you so much, and thank you for being with us.
Thank you, Andrew. Rachel, over to you. Your take-home message.
Yeah, thank you so much, Dr. Doreen. For me, my take-home message is that, as you said, we are building the system, we are building the emergency medical service system in Uganda, and everybody is very important. So as Joseph has said, if you can go back and get more training to get that skill, go back and train. If you're a driver, drive, don't just put the patient and run. Please move with a trained or a health worker. If you are the health worker, don't sit in front. Yeah, if you are the one who is receiving the patient, please try to do the systematic approach of managing patient with emergency. So let's build the system, and I believe we can.
Wow, wow, wow. This has been an amazing, amazing eco session. I want to thank the team here. I want to thank SEED Global Health. I want to thank Ministry of Health, and I want to thank you participants online. My take-home message to you is teamwork. As you can see, we are all here, we are in different cadres, we are all in different capacities, but the patient is the same. And the patient came from different facilities. Patient was in the ambulance, the patient was referred. But it took a collaboration of people to help improve the patient outcomes. So please, colleagues and friends, let's lean on each other. Let's build a system that will help our children, a system that will help our country. So for God and my country, I want to thank you all for attending this eco session. We shall now have our usual pictures. It's our tradition here during the eco sessions. Please put on your cameras. Dr. Anna, Clinton, Jerome, Louise, Penelope, Salome, Ida, please put on your cameras so that we can see and we take a picture. Are the residents still online? I need to see your faces. Let's see your faces and we take our pictures. Some of you, oh, I see Dr. Mahdi over there. Good to see you. Some of you at your workstations, there are some people who are in their facilities. Good to see your faces. Dr. Jerome, we see you. Nice to see you. All right, let's take our picture. All right, thank you all and have a lovely weekend. We shall see you at the next eco session. Bye, guys.
Bye. Bye-bye.